Good evening. Welcome to Bar-Ilan University and to this special webinar in a webinar series entitled When the End is Just the Beginning, the COVID-19 Vaccine Challenge. We're giving it a new subtitle, Which Vaccine Do We Think Professor Anthony Fauci is Going to Take? No, it's just kidding. And this is a very serious webinar series put together by tonight's webinar series speaker, Professor Michael Edelstein. And usually I have to make the introduction of him very short so we can take time to introduce the speaker, but I can take a little bit more time. Just a technical thing, point before I introduce and hand it over to Michael. We welcome very much, very big part of the success of the webinars has been questions and answers. So when you have questions that you want answers to or want to make comments, please put them up on chat, directed to Dan Gienenzen. You'll see the name, he's the host, he's one of the hosts. You'll see that name, should be there in the chat box. And then the questions will go to him. He'll organize them and make sure that I get them or that Michael gets them. So I'm Karl Skoretsky. I'm the Dean of the Faculty of Medicine here at Bar-Ilan University. I'm in Svat in my office. And it's a real pleasure to thank, first of all, Michael for putting together this webinar series, to thank the leadership of Bar-Ilan for enabling us to recruit Michael to our faculty. Thank Mary Rudolph, who's right here. You'll see who did the shidduch, the introduction between Michael and the faculty. So that's great. So Professor Edelstein, born in France, but educated in medicine in the UK, MD graduate, University of Birmingham, and then specialized in practice and research in public health at the London School of Hygiene and Tropical Medicine, where he has been an associate professor. He also spent a lot of time in the field. He did also study in Sweden, in the very interesting Swedish health system. And he's been involved in many aspects of public health related to infectious disease epidemiology, vaccination, including eradication of polio outbreaks in various parts of the world, and many other very important and significant field work. He, of course, in Public Health England or in the UK public health system, had been active with a large team of at least 100 members in which he had a leadership role, and is very well known around the world. We know that from the speakers he's been able to engage for this webinar series, but also from his many publications, supervision of students, and positions in organizations, such as being president of the Infectious Disease Control Section of the European Public Health Association, an expert group member in the Safe Immunization Data Quality World Health Organization, deputy editor of epidemiology and infection, consultant research fellow at the Center for Global Health Security in the UK, and many others, too numerous to mention, and not doing him sufficient justice for all his accomplishments in a very short time. And Professor Edelstein is interested not only in infectious disease epidemiology, in health inequalities in general through that lens, but through other lenses as well, in data sciences in medicine and how they can be harnessed to improve public health and reduce inequalities, for example. And he was appointed beginning of October, and we're towards the end of November, and in 2 months, his presence is felt very loud and clear at the faculty at Bar-Ilan in Israel. He's sought after by the Minister of Health and many other agencies in Israel in a very, very short time. And of course, has put together this excellent webinar series When we recruited, approached Michael, this was well before COVID-19. So, you know, this is part of the strength and focus of our faculty, population health. We feel, you know, we're going to make an impact in the Galilee and from the Galilee beyond to the rest of the world. And Michael is certainly one of the prominent and important steps, recruiting him in that direction. So I'm going to now hand over the session to Professor Michael Edelstein, and he's going to speak about it's all in the delivery, operational and logistical challenges in deploying a pandemic vaccine. How timely, it's unbelievable. You know, this schedule was set up quite a while ago, and exactly it comes when this exact question is at our doorstep. So we're all anxious to hear you, Michael, and handing over the microphone to you. Thank you.
Carl, thank you very much for the introduction. Before I start, I want to give a quick weather forecast. There's torrential rain here in northern Israel, and this has the habit of disrupting internet connection. So if things get a little bit choppy, just bear with us. It probably will hold, but it might freeze for a few seconds. Apologies in advance if that happens. Okay, I'm going to try and share my screen. Here we go. Oh, I need to. Can you see my screen? Can you hear me? Yeah, great. Okay, so as Carl said, it's actually a very timely talk. We didn't plan this exactly. We had no insider information about when the results will come out of for the different vaccines, but it's worked out very well. What I want to do in the next 30 minutes or so is really convey one message to you, which is, you know, the release and the availability of vaccine is really only the beginning. I was speaking with a colleague of mine a few days ago, and I thought the way he put it was very very spot on. He said, you know, there's light at the end of the tunnel, but we don't quite know how long the tunnel still is. And I think that's going to be the key message of this talk. So before I begin, I think we're all familiar with these figures, and we see them every day. But it's worth just taking 1 second to remind ourselves of the scale of this pandemic. 59 million cases, 1.5 million deaths around the world. It's been a very long time since 60 million people are infected with the same virus at the same time across the globe. And what's really striking to me, I've tried to reflect on this a little bit, and obviously we haven't, you know, there hasn't been a vaccine so far. There's been a lot of different approaches to trying and control this pandemic. And, you know, at the beginning, Asia was being, you know, Asian, Southeast Asian countries were being sort of promoted as, you know, the good, the best practice examples. Israel was doing very well as well, and then Israel started doing less well, and then Europe went up, and then there was the Swedish model. The bottom line is, I've looked at data from virtually every country. There isn't a single country that has truly managed to control this outbreak or this pandemic without a vaccine. There's been varying degrees of success, or probably varying, you know, it's been damage control. It's not been genuine control. And here you can see I've just selected a few graphs from countries that are, you know, supposedly the best at controlling this pandemic. South Korea, Germany, which is, you know, the top kid of the class in Europe, and you can see infections are going up. Incidence is increasing in pretty much everywhere. Israel, we've had it slightly ahead of time. We're out of a lockdown where other countries are entering the lockdown. My personal view at this stage is we're not going to control this without a vaccine. Regardless of what we do, we're not able to completely control the outbreak, and we're going to need the vaccine. Luckily, if you're into the vaccine world, it's been a very exciting week or couple of weeks, because literally within a space of a few days, several of the key vaccine manufacturers working on COVID vaccines have released preliminary data, and all of them have had tremendous, almost too good to be true, early efficacy results. Pfizer, earlier this month, 90% efficacy with their vaccine. We often forget that there are also vaccines manufactured in other countries like Russia and China. It's interesting that CNN says the scientists are cautious about the Russian vaccine. They're not really cautious about the other ones. It's an interesting way to put things. But nevertheless, again, very high efficacy, and you may or may not choose to believe the data, but it's pretty consistent. Moderna, another vaccine, American vaccine with an Israeli CEO, 95% effectiveness, and AstraZeneca, and we're very privileged to hear the chief investigator of these trials 2 weeks ago on our series, 90% effective. So again, a kind of consistent good message, which is really great news, and I think brought a lot of hope and prospects in the public health community. These are the most visible vaccines because they're the most advanced in terms of clinical trials. But it's worth remembering that there are actually literally hundreds of vaccine candidates around the world. WHO, the World Health Organization, maintains a database, and there are currently, as of the 12th of November, 48 candidate vaccines in clinical evaluation, of which I think 11 are in phase 3, so the most advanced phase of testing before being able to release vaccines on the market. So I think there's, we can expect more, and there's a lot of vaccines developed in China, in Russia, that are not necessarily targeting markets in Western Europe, in North America, in Israel. So we don't hear about them as much, but they're also, progressing, and actually some of them have released early data, which is also promising. But today I want to focus on the 3 key vaccines that we've mostly heard of, and because they're the ones that are most likely. I mean, I say we, I realize the audience is very broad, and there are people actually from most continents on this call, which is really really heartwarming to see. But these are the vaccines in terms of Europe, North America, Israel markets. They're probably the ones that are going to be available first. And they're quite different, all of them. They rely on different technologies. Moderna and the Pfizer vaccine rely on an RNA technology, which is completely new, which hasn't really been used in any vaccines previously. The AstraZeneca vaccine relies on a more classic inactivated virus vector. They've all shown very high efficacy. For those interested in the small print, the AstraZeneca vaccines had a very interesting finding, which is if those who receive half of the first dose actually are better protected than those who receive the full first dose. It's not entirely clear why that is. It's quite puzzling. It's an interesting finding, but nevertheless, all of these vaccines have pretty high efficacy. But there's not a lot of detail beyond that, and really the devil is going to be in the detail, because the first question that we need to think about is efficacy against what? The efficacy of a vaccine can be against many things. It can be against developing clinical disease. It can be against infection. So you can actually prevent people from being infected. It can not prevent infection, but prevent people from actually being sick and unwell. Or it could actually prevent severe disease. So it may not prevent infection, it may not prevent mild disease, but it will stop people progressing to very serious disease and dying. And examples of these vaccines, I mean, there are vaccines that exist that fits all of these different types of endpoints. And it's not, to me at least, I haven't seen definitive data for the vaccines that very explicitly say what the vaccines are efficacious against. And that will become important, and we'll see why in a minute. The other thing to think about is, who are they efficacious in? Most of the trials generally recruit healthy adults. These trials have, by and large, excluded children. So we don't know anything about efficacy in children. There's been a few older adults in the trials, and the results in these older adults are also very encouraging, and that's very important because the older adults are the group that is most severely affected and most likely to develop severe disease. But we'll go into that a little bit more, because in terms of planning and delivering a vaccine, it becomes very important who you're going to prioritize. The other factor that we know very little about is the duration of protection. How long, once you get immunized, how long are you protected against the disease? And in the world of vaccines, there are a whole range. Some vaccines protect for life. You know, if you get 2 doses of hepatitis A vaccine, if you get 2 doses of measles vaccine, you're pretty much protected for life. If you get typhoid vaccine or flu vaccine, you're only protected for a year or maybe a couple of years, and this will have huge implications. And we'll come back to that. We know nothing about it at the moment. Another important factor is how many doses do you need to be fully protected, and all of these vaccines require 2 doses, which logistically makes it more complicated than a single dose vaccine, because well, obviously you need twice the number of doses to protect. So when you see number of doses, you have to halve it to think about how many people can get immunized. And we'll see that efficacy and effectiveness is not the same thing, and this is partly because out of those who receive the first dose, a proportion, sometimes a significant proportion, never receives the second dose because they forget, because they move, because the system doesn't pick up that they haven't had their second dose. So automatically it will reduce the effectiveness of the program. And again, we'll develop that. Another factor which brings logistical complexity is storage temperature. Now, most vaccines, most childhood vaccines and vaccines that are in the routine programs of most countries are stored between 2 and 8 degrees they can be stored in a regular fridge with a little bit of temperature control. The Pfizer vaccine, which was the first vaccine to release data, needs to be stored at -80 degrees. That's very cold, and that requires an infrastructure that even high-income countries don't have in place. And to put that in place is no small feat. I'm not even talking about low-income countries having to deal with this, although I will in a bit. And the AstraZeneca vaccine is in this way much more promising, because it can be stored in a normal way, in a normal fridge, and that makes it much more suitable for a wider variety of contexts. And the Moderna vaccine is somewhere in between. It has to be stored long term at -20 degrees, but it can survive in a fridge for about 30 days. And the last thing, well, the next thing is the cost of the vaccine, and again, that will determine to a large extent what vaccine is used where, because there's almost a tenfold factor of price between the cheapest vaccine, which is the AstraZeneca vaccine, and the most expensive one, which is the Moderna one. And in terms of equity, that becomes very important, because you know, ability to buy and public health needs are not always aligned, and we'll see how the ways to overcome these differences. Finally, a lot of people need COVID vaccine. This is a global pandemic, and ideally you would want as many people as possible to be vaccinated. And the aspirations of the vaccine manufacturers have been downgraded somehow. And although the vaccine it looks like at least some of these vaccines will be available really imminently in the next few weeks, by the end of the year, the number of doses is not going to be on the scale needed to control this pandemic at a global level yet. There's planned massive expansion in 2021, which in volumes that are sufficient to do this, but it's not going to be in the very first instances following the release of the vaccine. So for all these reasons, vaccines are not going to be a silver bullet. There are characteristics of the vaccine themselves, issues with vaccine supply, issues with demand for the vaccine that mean that the release and the availability of the vaccine is a fabulous and fabulously exciting news, but it's not the end of the story. So let's explore why. Okay, so the first thing I want to do is look a little bit beyond the 95% efficacy, the 90% efficacy figures that we've seen released by the vaccine manufacturers. And these are obviously great figures, but it's important to understand what they are. They're efficacy figures from clinical trials. Now, clinical trials are not real life. Clinical trials are the public health equivalent of lab experiments. And that means that it's a very controlled environment. It's an environment where people volunteer to be part of trials. There's teams that are dedicated to following every single patient to know exactly what happens to them when they had the vaccine. If they didn't, if for some reason they didn't receive the vaccine, they will do everything possible to receive that. And we know that in real life that doesn't happen. When a vaccine is offered and moves from a trial to a vaccine program, there's only a certain proportion of the population who's going to be vaccinated. So here I've picked up two examples from the UK because I'm mostly very familiar with the UK data. HPV vaccine and MMR vaccine, and both of these vaccines share characteristics with the COVID vaccine, which are the multi-dose vaccines. So you can see with the HPV vaccine, which in the early stages of the vaccine was a 3-dose vaccine, and you can see in the initial year that although almost 90% of the eligible population received the first dose, there's only 80% that completed the course. Similarly with measles, if you look at the MMR vaccine, the measles-containing vaccine, about 95% of the eligible population in the UK receives 1 dose, but only 85% receives the complete course. So already you can see that the 95% figure is going to go down once you implement this and scale it up at the scale of a program. And this is assuming that in these two examples, measles and HPV, the vaccine is offered to everyone who's eligible. It's offered to every single child and every single teenager in the country, and that requires a sufficient number of doses being available. With COVID, in the initial phase, which is really the end of this year and the beginning of this next year, if you combine all the vaccines together, excluding China, because China is developing their own vaccines that are mainly targeting the domestic market. But if you combine most of the rest of the world, you're only going to have 300 million doses, which means roughly 150 million people who will be able to receive 2 doses. That is, less than half of the population of the United States. It's not really enough to stop the pandemic very, very rapidly. Interestingly, though, there's efforts and global efforts to scale up in a way that is completely unprecedented in the world of vaccine. The vaccine manufacturers are licensing and outsourcing manufacturing to other vaccine manufacturers, they're direct competitors, because I think there's a realization that this is a completely unprecedented scenario, and you have this, for example, this agreement with between AstraZeneca, who's a British company, and the Serum Institute of India, which is the biggest vaccine manufacturer you've never heard of. It manufactures more vaccine than anyone else in the world, but only provides pretty much only supplies vaccines to low-income countries, mainly India, Sub-Saharan Africa, and if hello?
Oops. You were just off for about 30 seconds.
Okay, I'll resume. Sorry, I lost my connection. I did warn you that may happen.
Just I'll use the break. Again, chat questions to faculty of medicine. You'll see faculty of medicine. You can send it there. Okay, just go ahead. Sorry, Michael.
Okay. Can you see the screen?
Yes.
Yes. Okay, so I was talking about the sort of unique arrangements that are being put in place to scale up, but again, that will take time. And people talk a lot about the manufacturing bottlenecks in actually manufacturing and producing vaccine doses, but there are other in the production process. You know, there's never been so many doses being produced so rapidly by so many different vaccine manufacturers, and that's leading to shortages in vials, in syringes, in packaging. You know, it sounds very trivial, but you cannot distribute a vaccine if you don't have vials to put the vaccine in. So it's not just the actual process of making the vaccine and the doses itself. It's the whole chain and the whole logistics chain around it that needs to be scaled up at speed. And normally, what takes 5 to 10 years, the chain of events that Professor Pollard explained 2 weeks ago, that you go through the trials and then once you have an effective and efficacious vaccine, you scale up manufacturing. This is all compressed with manufacturers taking a huge risk by building you know, factories to do this even before they know whether or not their vaccine is effective. So it has the effect of massively compressing the time scales, but nevertheless, it still does take time. So, with a limited supply in the initial phases, there's a need to prioritize doses, and there's really two levels of prioritization. The first one is prioritizing at the macro level, what I've called Micro-Prioritization, which is which countries get the vaccine. And that is a tricky question because there's many different ways that this can happen. I'm not talking about which one is ethical or not. I'm talking which ones are possible and are showing a likelihood of happening. The first one is national preference. You know, a US manufacturer will give preference to the US market. A British manufacturer will give preference to the British market. We may have an Israeli vaccine in the future. You know, the expectation would be that it would give preference to the Israeli market. The other possibility is market forces and who's willing to pay, you know, who's the highest bidder, and the highest bidder gets the vaccine. And then there's two other options. One is equality, which is this is a global pandemic and everyone's affected and therefore everyone deserves to get some doses. And the final approach is equity, which is you give the vaccine to those who need it the most. And it's not an easy. It's what actually is happening is in reality is a combination of all of these four forces that are driving prioritization. It may seem intuitive to think if you're lucky enough to live in a country which is manufacturing a vaccine, you may think that you know, it makes sense and you would benefit, or the country would benefit from having this particular country being prioritized. But it's useful to go back to the beginning of the outbreak and remind ourselves that we went from, if you look at the situation on the left, the little map on the left, which is early or sort of mid-January, which, you know, was really a national or best a regional outbreak with provinces in China and a couple of cases in Thailand. And in the space of months, we went to this, from this situation on the left to this situation on the right, with every single country being affected. And the way this happened is because of globalization, travel, trade, and the volume of travel and trade. And that has a consequence in terms of outbreak control. And this is really the basic principle of global health security. The world's collective preparedness is only as strong as its weakest link. So vaccine nationalism may actually be counterproductive and be less efficient and effective on the long run than more equitable or equal sharing of the vaccine. And it may be that by focusing on a nationalistic approach to vaccination, you protect your own population, but you're not going to be able to restart the economy. You're not going to be able to restart travel. So it's really food for thought about you know, the intuitive and sort of selfish solution is not necessarily actually the most effective one. And obviously, most countries in the world do not manufacture vaccines. They don't have they don't have the infrastructure. They don't have the companies embedded into the countries. So recognizing that this is a global crisis, several global organizations like the World Health Organization, like Gavi, the Global Alliance for Vaccine, have started something called COVAX, which is essentially a mutual fund for vaccines. And every country chips in, and as a result, every country gets some vaccine. And the COVAX has taken an equal, not an equitable, an equal approach to vaccine distribution. And what they've suggested is a three-pronged approach to prioritization. The first one is giving enough vaccine to everyone in the world to protect the healthcare workers and the social care workers. And the estimation, this is roughly 3% of the population in most countries, give or take. Once 3%, once all the healthcare workers in all the countries have received the vaccine, they go to the stage 2, which is 20% of the population, which is focusing on elderly individuals and high-risk individuals, or older individuals and high-risk individuals, I should say. And the last stage, once this is completed, is to then go to further priority groups that can be decided by each country individually. And no country will receive more than 20% of their vaccine for their population before others in COVAX have received it. Now, I think about 170 countries have signed up to this initiative. Notably, the United States hasn't. And both Moderna and AstraZeneca have signed up, but Pfizer hasn't. And there wouldn't be the being part of COVAX does not preclude you from also having bilateral agreements with vaccine manufacturers. So you're only limited to the 20% as part of this initiative. You can top it up with individual agreements, and obviously richer countries are more likely to be able to do this. So this is really the macro prioritization, and then within countries you have to decide who gets the vaccine, because there's not going to be enough for everyone. So the World Health Organization has recommended, as we've seen, healthcare workers first, older adults second, and high-risk individual third, which makes sense because these are the most vulnerable individuals. And similarly, individual countries have taken the example of the UK here. The US has taken a very similar approach. There's really a focus on high-risk individuals, and it sort of decreases. You know, the more doses you have, the lower you go in terms of age priority until you get to the whole population. But this is it sounds very logical to vaccinate those who are most at risk of being sick. But I want to present to you a slightly counterintuitive approach to prioritization, and I don't have the right answer because there isn't a right answer yet. And it goes back to the issue that I presented early on about what is the vaccine effective against? Is it effective against disease? Is it effective against serious outcomes, or is it effective against transmission? Does it stop transmission? Because knowing this changes the logistics, changes the prioritization, and may change who you choose to vaccinate. And let me explain why. If we look at how the outbreaks evolved over the last year or so, in the first wave, most countries experienced very high incidence in older individuals. You know, the mortality and the incidence in the 80+ in most of Europe, in Israel, in the US was very high, with very high mortality, fueled by outbreaks in care homes, nursing homes. But that's changed. And if you look at the recent trends in age-specific incidents, in what age groups are actually most affected, what you see is a shift towards younger age groups. On the left, you can see US data, and you can look at the median age and how it's changed over time. And this is just between May and August, and that trend's continued. What you see is the median age going down and down and down. And it's seen all over the world. In the US, you've seen a 50% increase in incidence in the 18 to 20 age group between August and September in the space of 1 month. In March, in September in the UK, the 20 to 29-year-old was the highest incidence, whereas it was the 60 plus early in the outbreak. And you see 3 times more the incidence in the young in the young adults and older teenagers is about 3 to 4 times what it is in older adults. And this is important because even though these individuals are not are less likely to develop severe outcomes, they're less likely to die, they're less likely to be admitted to hospital, they are driving the outbreak. They are the ones who are infecting others. So deciding and prioritizing here becomes a decision on what do you want to achieve. Do you want to protect those who are vulnerable against a circulating disease, or do you want to stop the transmission of the disease altogether? And although it sounds counterintuitive, vaccinating those who are the least vulnerable may actually be the quickest way to stop the outbreak. And if you think this is very far-fetched, it's not, because that's a very commonly used strategy for many other vaccines. And let me show you a couple of examples. This shows incidence of invasive pneumococcal disease caused by Streptococcus pneumoniae. And this is a vaccine preventable disease. And in 2006, the first vaccine against pneumococcal disease was introduced, and it protected against 7 different types of pneumococcal disease. And I want you to focus on the over 65 at the bottom right, which I've circled, and you can see that within the space of just under 10 years, the red line, the serotypes, the types of pneumococcal bacteria that are targeted by the vaccine has virtually disappeared from the population. And the really interesting part is these people are not vaccinated. The people that are vaccinated are the under 2-year-olds. And this is the indirect effect of vaccination. And actually, when modelers look at the data and decide who to vaccinate, in this particular case, it was more effective to vaccinate children to protect older adults than to vaccinate older adults directly. And it's not an isolated case. You have the same thing with influenza. If you look at the right graph, which shows the incidence. So this graph shows the incidence of influenza. This is modeled data. Influenza incidence in the elderly after vaccinating in different age groups. What you see is if you vaccinate, so the incidence curves, the red ones are if you vaccinate children, and the blue ones are if you vaccinate older individuals. There are scenarios if you vaccinate children up to the age of 10 or so, and you manage to achieve 75% coverage, you actually protect elderly people against influenza better than if you vaccinate them directly against influenza. So it is a strategy that is used and worth thinking about. And I don't have the right answer, because there's obviously an immediate need to protect the most vulnerable, but to protect those individuals are unlikely to are probably less likely to spread COVID to others, because by and large they have less social contact, they feel more vulnerable, they self-isolate more, and that actually may delay the complete control of the pandemic. You can even take it one step further, and again, I'm not suggesting this is what we should do, but it's interesting to think about. We now know that the transmission of COVID is not straightforward. It's we know what the reproductive number is. We know that on average each case infects 2 to 3 other people, but this is an average. And in reality, when you unpack this 2 to 3 cases per 2 to 3 contacts per case, what you actually see is that most people who are infected with COVID don't infect anyone else, and a small minority actually infects most others. So there's an argument that you know, I've seen it written very elegantly, suggesting that perhaps the best way to control the outbreak is to focus on on people who have most social contacts, regardless of their clinical risk. Which is also an interesting and innovative way to look at prioritizing. And in reality, you probably need to combine these approaches to protect the most vulnerable while beginning to bring the outbreak under control. But you can't do this immediately because of the number of doses available. Cold chain is another challenge, and as we've said, most vaccines are stored in at fridge temperature, but here we have a couple of vaccines that need to be frozen, and that's going to be a challenge. It may mean that for some countries, the Pfizer vaccine and to some extent the Moderna vaccine are not going to be realistic options, and even in countries with good cold chain, there's a higher risk of cold chain failure. Having said that, it's useful to remind ourselves that 3-4 years ago there was an Ebola outbreak in West Africa, affecting the countries with the weakest public health infrastructure in the world: Sierra Leone, Guinea, Liberia, and there was an Ebola vaccine that was developed very quickly, not quite as quickly as this one, as these ones, but within the space of 2 to 3 years, and they also needed to be frozen at -60 degrees. And someone found a solution. Someone invented this this device called the Arctech, which actually does enable you, without electricity, to keep vaccines at -60 degrees in sub-Saharan Africa for extended periods of time. So it makes it more complicated, but it's not an absolute barrier to disseminating these vaccines, even in environments with weak public health infrastructure. But nevertheless, it shows the value of having more than one vaccine and being able to allocate vaccines according to circumstances. Another bottleneck and another logistic barrier is workforce. I've just put a press release about the influenza vaccine campaign this year in the UK, with a plan to vaccinate over 30 million people in the space of 6 months. And that would be unprecedented. That's the biggest flu vaccine campaign ever. Normally it's about 12 million people, and that puts an immense strain on the workforce. Now, a COVID vaccine program, once sufficient doses are available, would dwarf that, to the extent that the government in the UK has recognized that you know, there's simply not enough nurses and doctors in the country to vaccinate everyone. So they changed the law to enable other allied healthcare professions like midwives, paramedics, physios to vaccinate, to increase the workforce. But that has training implications. You need to train these people on how to vaccinate, and you need to consider that you know, these are already exhausted people. You know, healthcare workers all around the world have worked really to have been pushed to their limit, and you know, asking them to suddenly take on the biggest vaccination effort ever taken in the history of mankind is not going to be a small feat. And again, I have more. I'm bringing out the issues. I don't have the answers. Another issue that we need to think about is vaccine demand, and you know, you can give the vaccine, you can make the vaccine available. If people don't want to be vaccinated, you're not going to protect the population. And I'm just sharing this with you. This is a poster that I saw in just outside my office in Tzfat in northern Israel, and I've just translated it. You know, it's basically saying COVID is a lie. We're exposing the truth about corona and vaccines. If you want to hear more, visit this website or call this number. I haven't tried to call, so I don't quite know what they have to say. But this is not unique to Israel. It's happening all over the world. Vaccine hesitancy is a well-described phenomenon, and you know, it may be worth. It may actually be amplified by COVID because these are new vaccines. There are new technologies, and this is a study from Israel actually showing that the willingness to be vaccinated is not that high, and it's not even high amongst healthcare workers, let alone the general population. About 3/4 of the population are would be willing to receive a COVID vaccine, which is not bad. But you have to, and we'll see that in a minute, in the minute. And I'm almost finished, so we'll have time for questions. These percentages are multiplicative. So you actually, each time you have another step, you decrease the proportion of the population who's going to be protected. The other and the last point I want to make is about data, because, you know, as we say, in anyone who's trained in medicine will know that, you know, if it's not recorded, if you don't write it down, it never happened. And that's true for vaccines as well. You need comprehensive, granular, and timely data to monitor the program, because without that, you don't know who's immune, you don't know what proportion of your population is protected, you don't know if you're achieving your goals, and you don't know where are the pockets of under-immunization that are going to perpetuate the outbreak. And this is complex in normal times, but when you start delivering vaccines in primary care, in pharmacies, in hospitals, in mass vaccination centers, on car parks, and you need to bring all the data together in a single source, to be able to invite people who haven't quite responded, who eligible but haven't received the vaccine, or to remind them that they're due their second dose, it becomes, from the IT perspective and the data perspective, a very complex enterprise. And again, that has the potential to delay a full and comprehensive vaccination campaign. So I just want to conclude very quickly by saying that a safe and effective vaccine is really, in my opinion, the key to ending the pandemic. But there's a lot of things that need to happen after this. Once we have the vaccine, it needs to be packed, it needs to be stored, it needs to be distributed, it needs to be given, it needs to be accepted, and it needs to be measured. And each of these things can go wrong, and there will be bottlenecks, there will be limitations at each of those steps. And I just want to sort of try and model this, making a few assumptions. So we have our vaccine with 95% efficacy, and let's assume for a second that it's protective for 1 year, and if you receive one dose, the efficacy is 80%. So let's say that we have enough doses in the first year to offer it to 70% of the population. And of these 70%, this is very optimistic, by the way, we're not going to have 70% of the population in the first instance in most countries. Of these, 80% choose to accept the vaccine, which is higher, which is an optimistic scenario compared with the data that I've showed. And of these, 90% receive the 2 doses, but 10% don't receive the second dose for some reason. And I've skipped a lot of steps, but just with these 4 steps, you can do the math yourself. You get about half of the population who's directly protected against the vaccine. So we're very far from the 95%. So yes, vaccine is going to be a game changer for managing the COVID pandemic. And the early results are very encouraging. And it's fantastic to see positive results from different manufacturers, because this is not first to the, you know, it's not that the first one to reach the finish line wins. There's really a need for more than one vaccine. Because there are so many different contexts, you know, rich countries, poor countries, et cetera, but there are many unknowns still. We don't know anything about the duration of protection. We don't know anything about the indirect effect and whether the vaccine will actually stop transmission in addition to protecting people against severe disease. We don't know anything about the 1-dose efficacy, which is important because a proportion will never receive the second dose. We don't have a complete clarity about efficacy by age, and there may be a need to combine these vaccines. You know, 1 dose of Pfizer vaccine followed by 1 dose of Moderna vaccine, and we don't know what that's going to look like. Even though there are some initiatives put in place to measure that. And vaccine efficacy, as we've seen, is not the same as program effectiveness. So I hope you share my enthusiasm for the 95% efficacy, but I hope I've nuanced that a little bit. And all this means that vaccine will be an addition rather than a replacement to existing measures to begin with. So don't bin your masks just yet. Thanks.
Thank you very much, Professor Edelstein. That was extremely thoughtful, comprehensive, timely, and much needed. And it's being recorded, just like you said, data needs to be recorded. So your session is being recorded, and we'll relook at it again a year from now. Let's see. In any case, we have very many questions, very thoughtful questions, and in order to be able to try to get as many as possible, I'm going to just go through them in the order they came in, read them to you, and if you can give us, just keep in mind that there are many questions, okay? We'll try it, and I'd like to try to get them all in about 10 minutes or so. By the way, during your talk, Professor Shinwell, who's on the line, Associate Dean for Medical Education, and I we're writing back and forth about having our medical students trained and licensed to administer vaccine and to help the public situation.
Yeah.
Okay, so the first question actually came from Mary Rudolph, Professor Emeritus Mary Rudolph. Is the immunity you get from vaccine different from the immunity you get from having disease and recovering?
So in general, it depends. Mostly, for most diseases, natural immunity is, in terms measured by antibody response, is higher by orders of magnitude with natural infection, and it tends to last longer with natural immunity compared with vaccination. But it's not the case with every single vaccine. And there's actually, I can think of one example, which is HPV, where the vaccine response is actually better than the natural response. So the answer is it depends, and we don't really know. It seems that from what we know, which is not a lot, natural immunity following natural infection is not going to last a lifetime. It may last a year or a few years, and it's unusual for as I've said, it's not unheard of, but it's unusual for a vaccine response to outlast natural immunity. So it is likely, and I'm sure if we watch it in a year's time, I'll be wrong. That's fine. It is likely that we will, this is a vaccine that will need boosters on a regular, every few years.
Thank you. Great. By the way, if you can share Michael if you'd like, so we can see as many people on the gallery as possible and share your screen. Or you can just move. Of course, you can move the, and everybody else can move the PowerPoint to the side. I don't know if you want to unshare.
Oh, is it not? Is it not? Oh, sorry. I'm sorry. I thought I had stopped. I apologize.
Okay, there we are.
Here we go.
Okay, next question is from Ayelet Bar. Are there Israeli data regarding HPV and MMR similar to the ones that you presented from the UK?
So Israel's got a slightly, especially for MMR, higher coverage compared with the UK. It's around, the national average is about 96%. But the what I wanted to illustrate is not the coverage of the UK, is the fact that the second dose coverage is lower than the first dose, and this is true anywhere in the world, including Israel.
Are the Tipot Chalav in Israel somehow allowing better second dosing, for example? The infant milk program or those?
Yes. I mean, it's a 2-dose program as well. Everywhere in the world has a 2-dose.
Yeah, everywhere in the world, of course. Okay, so we have a number of questions and comments from John Pearman. Just a comment, I guess, that there are developing countries that are making vaccines. India 4, as you mentioned, Indonesia 1, Korea 2, Brazil 1, China 3. Which may finish capacity and greatly assist production during the course of 2021. If they take off with 100 million doses per month for each of the suppliers, we could get better supply. You had mentioned, Michael, that they may be for the local population, domestic only, etc. So I guess that's a comment.
Yeah, the only thing to comment about, and again, COVID changes everything, but it's quite difficult. It's proved difficult to for the regulatory authorities in high-income countries to license vaccines made in China, India, generally because the quality assurances process are different. But it's this is an exceptional situation, and exceptional things have happened, so it's not impossible. I think there is definitely a kind of global joint approach to this, which has never happened before. At least I've never seen happening before.
Okay, Christine Ben anticipated your issue by mentioning that surveys show that only percentage, about 50% of healthcare workers express a current interest in taking the vaccine. You showed some of that data. John Pierman also writes the data on median, your data that you presented, or the data that you presented, and others, that on median age reduction might be from the school university attendees going or in summer break, need to update now that they may be back in school September, October, November. Anita asks the following question: how do you deal with previously infected persons who may have been asymptomatic or unaware of the previous infection? I guess we talked about this in the past with enhancement, and if there's limited doses, should people look at their own endogenous antibody levels so we can save people getting doses they don't need? Could you address that?
It could be. I mean, it sounds reasonable. We don't know anything about the additional benefit of vaccinated someone who's been infected. It may be that because natural immunity wanes, the vaccine actually boosts their response. There's also, this has been suggested for many diseases, but there's actually an opportunity cost, because then you have to test everyone and you have to process those the samples, and it may actually be cheaper and easier to just vaccinate everyone, providing that it is a safe thing to do, which it seems to be.
Yeah, great. Two last questions, and then I'll just want to announce next week's meeting, next week's webinar. From Dominica Susada. If best scenario, if we have another 10 to 20 manufacturers with good results next year, what will your prediction be in terms of vaccine coverage and decrease of incidence? Let's say the scenario comes along, even domestic, hundreds of millions in China. So you don't need 6 billion doses, but maybe.
Okay, so if we assume that vaccine availability is no longer an issue, which is kind of the scenario that he's proposing, I think the closest thing that you can think about is influenza, and actually, interestingly, in the study by Amiel Dror, the acceptance of COVID was higher than acceptance for the influenza vaccine, which is, a vaccine with which we've had 20 years of experience. I mean, there's many different flu vaccines, but so that's quite encouraging. And I think, maybe 70 to 80%, possibly more coverage sounds achievable. And it's worth reminding that, specifically if you give the opportunity for those who are spreading and driving the disease, which is mainly young active people, of which a high proportion are asymptomatic, you don't need to get to 100%. This is the concept of herd immunity. Herd immunity has been completely misrepresented in the media in this pandemic, but the bottom line is you do not need 100%. This, with an R naught of 2.5 to 3, once you reach 50, 60%, you actually start to make a serious dent in transmission. And once you get to 70, 75, you can get it under control, and then you can top that with managing local clusters and outbreaks using surveillance, contact tracing, etc.
Thank you. Final question from Susan Solomon of American Friends of Bar Ilan. Is the cost of different drugs related to profit issues? Are they cost issues? Moderna costs 10 times more, whatever, more than AstraZeneca because they're trying to make a lot of money, or because it costs them more because it's an RNA vaccine, or would you rather not comment?
I
ask for donation to for Bar Ilan.
I don't have a final answer, but I think it's probably a combination of both. I mean, you have to remember the vaccine manufacturers are for-profit companies. The larger ones, Pfizer is a very large company, and they can afford, or AstraZeneca as well. They sell, they can offset the costs of the vaccine with their diabetes drugs or with other drugs, so they can actually sell it for no profit. Moderna is quite a smaller company, and it is a new platform. So I don't have any shares in any of them, so I don't have a conflict of interest. But yeah, I think it's a mix of both.
Great, thank you, Michael. So I think what we've heard is this book. I guess you probably know these people, may have met the people. He's not lying, Lars Hansel Rosling from Sweden, called Factfulness, and the whole factfulness movement. I think hearing you, Michael, gives us this opportunity to hear fact-based, knowledge-based sound. What you know, what you don't know, you say you don't know. different than what we hear on the news all the time. And therefore, it's so important. That's why these webinars by experts that you've put together are so important in your talk tonight. Deeply appreciated at this time, and looking forward to next week's session, which is November 30th, 6 p.m. I saw Ravit Barkama she is among the audience, so she's listening in, and we're going to hear her next week. She's in New York at Holy Name Hospital, and her talk will be treating patients, testing patients, a hospitalist at the forefront of COVID-19 treatment. So I see she's turned on the camera. Ravit, hi. See you in full regalia next week. Great. So thank you, everybody. Thank you, Michael. It's been wonderful. And stay healthy, everybody. And we'll see each other soon. Take care.
Bye-bye. Thank you.